Hereby, I open this academic ceremony in which Lieke Maas will defend the academic thesis Optimizing Quality of Care in Osteoporosis and Epilepsy Surgery and Patient-Centered Care and Economic Assessment. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you, Pro-Rector. Dear Pro-Rector, dear members of the Corona, dear family, friends, and colleagues, today I feel honored to explain to you in an easily digestible format the content of my thesis, which is about optimizing quality of care in 2 patient groups looking at patient-centered care and economic assessments. Before I explain to you the content of my thesis, I want to explain to you the concept of quality of care. Good quality of care is based on these 7 pillars. So besides good care needing to be safe, timely, and effective, it should also be patient-centered, meaning that it should be, care should be aligned with the patient's preferences and values. Care should also be equitable, meaning it is available for anyone regardless of their background. It should be integrated, meaning the healthcare providers are well coordinated between one another. And it should be efficient, meaning it's affordable for both patient and society. And although my thesis will focus on these 2 pillars, patient-centered care and efficient care, it is important to highlight that these 7 pillars are equally important and that in practice, often these pillars interconnect and overlap. To prevent that quality of care is a new area of research where we evaluate quality of care in a real-world setting, and to prevent that the results of clinical trials don't optimally reach the patient in the clinic, it is crucial that we evaluate quality of care based on these 7 pillars on the side. Now, within this thesis, we focus on 2 quality of care settings, where one, we evaluated a intervention that was aimed to optimize quality of care, and on the other side, we evaluated a patient care pathway as it is. Additionally, whilst one side or one setting was focused on patients with a recent fracture at risk of a new fracture, the other was focused on patients with drug-resistant epilepsy undergoing surgery. These 2 settings are additionally different, as one was aiming to be preventative and the other was aiming to be curative. And whilst one was focused on a drug treatment, the other was focused on a surgical treatment. I will now explain to you the research we conducted in the first setting, where we evaluated an intervention that aimed to optimize quality of care. So being over the age of 50 and having recently broken a bone is a clear warning sign that a new bone could break and that this is due to osteoporosis. Fracture liaison services, which is a healthcare program, was set up in 1999 to identify these patients more timely and give them timely evaluation, diagnosis, and treatment with anti-osteoporosis medication. We see now that the adherence to this medication is still suboptimal. So therefore, within this thesis, we developed an intervention, which was the patient decision aid. Then we analyzed the patient-centered outcomes between patients who received the intervention and those who did not. And we looked at medication adherence, shared decision-making, and quality of life. And we analyzed efficiency outcomes. The questions we wanted to answer is the intervention, so the patient decision aid, actually understandable for patients? And is it feasible to be implemented into the clinic? How are the patient-centered outcomes different between those who received the intervention and those who did not? And is the intervention actually affordable for patient and society? For the patient decision aid, it was an 8-page document that was used within the clinic between the healthcare professional and the patient. It focused on information such as general information on osteoporosis, but also the influence of lifestyle factors, and an option grid, so an overview of treatment options and their characteristics. We then interviewed 10 patients and 5 members of the Dutch Osteoporosis Association to understand the feasibility and usability of this patient decision aid in the clinic. And overall, both patients and members were very positive about the implementation and usability of this decision aid. And there were some suggestions for improvements, such as adding more specific information, simplifying terminology, and optimizing icon use. We then implemented this intervention into a real-world setting, the Fracture Liaison Services, which was a healthcare program, and analyzed the difference between the patients that received the intervention and those who did not. And we saw that there was no effect on medication adherence, but we did see that patients who received the intervention felt generally more involved in their decision-making process compared to those who did not. We then split up the groups between health literacy, where patients with limited health literacy generally struggled more with understanding the health instructions and information compared to adequate health literacy, who generally did not struggle with such information and instructions. And we saw that patients with adequate health literacy felt generally more involved in the decision-making process when receiving the intervention compared to those who did not receive the intervention. Looking at efficiency outcomes, we saw that compared the two groups with intervention and the control group, for every 1,000 patients, 5 fractures were prevented when the intervention was used. Additionally, patients who received the intervention had a slight quality of life increase over their lifetime, and patients who received the intervention were generally 16 euros less costly compared to those who did not over their lifetime. It is important to note, though, that the additional cost needed to implement this intervention was a big determinant on these outcomes. Now I will explain the research we conducted in the second setting, where we evaluated a current care pathway. So epilepsy is a condition that affects the brain where repeated seizures occur. And normally these seizures can be controlled by receiving anti-epileptic drugs. A proportion of these patients don't respond to these drugs and therefore are labeled drug-resistant epilepsy patients. And these patients can still be helped, though, by undergoing resective brain surgery. This is where they take part of the brain out that causes the seizures, hoping that the seizures will go away. And although the patient-centeredness and the effectiveness of this intervention is well studied, the efficiency of it is still unclear. So within this thesis, we first carved out the entire patient pathway. We analyzed how patient-centered outcomes changed before and after the surgery. Then we analyzed the efficiency outcomes, but we also tried to analyze what the determinants are for higher cost after surgery. The questions we wanted to answer is, what does the patient pathway actually look like? How do the patient-centered outcomes change? And here we looked at quality of life and seizure frequency. How much does this care pathway actually cost in practice? And who tend to have higher costs after surgery? So the patient pathway started from the moment the patient stepped foot into the hospital with their very first symptom of their seizure until they were diagnosed with drug-resistant epilepsy, undergoing surgery, and then we followed them for 2 additional years after surgery. We collected data from their patient files and from self-reported questionnaires. Now I will first talk about the very first part. So you see at the left bottom of the slide, the moment they stepped foot into the hospital up until undergoing surgery. The period before drug-resistant epilepsy diagnosis lasted for about 12 years on average, and cost ranged between 5,000 and 237,000 euros per patient. If we then looked from the moment they were diagnosed with drug-resistant epilepsy up until undergoing surgery, this lasted for about 2 years, and cost ranged per patient between 18,000 and 138,000 euros. Then looking at the really close cost around the surgery itself, so 3 months before undergoing surgery up until 1 year after, and you see obviously costs are higher in the beginning, the surgery is also included, but decrease over time, being about €6,000 per patient on average in the last half year. The total cost of the first year is on average €62,000 per patient. And lastly, looking more at the 2 years follow-up, we saw that the cost range between €3,000 and €91,000 per patient. And at the end of the 2 years, we saw that half of our patients had a quality of life increase and 2/3 of our patients maintained seizure-free. Now lastly, what type of patients actually have higher costs after surgery? We saw that those who had a quality of life increase after surgery had higher costs after surgery, but also those who had previously tried a ketogenic diet, had previously already undergone surgery, who were this time operated on the left hemisphere, and those who already had higher costs before their drug-resistant epilepsy diagnosis. Now the conclusions. So I hope that I've now explained to you the importance of quality of care research in 2 different settings. We saw in one setting where we evaluated an intervention that improved quality of life, quality of care. We saw that the intervention was well accepted, that the implementation should be patient-centric, hinting at health literacy results that we saw, but is also cost-saving. If we then looked at evaluating a care pathway, we saw that for drug-resistant epilepsy undergoing surgery, it was a lengthy process, but patients did improve over time. It was also a costly process. And with this research, we hope to set a first step into the direction of creating a patient profile that could benefit most from this surgery. If we then zoom out on a more quality of care research point of view, we can see that one size really does not fit all, and that patient involvement is crucial if you want to optimize quality of care. Lastly, by linking patient-centered care with metrics such as quality, cost, and values, we can truly understand the impact quality of care has on the patient and on society. I will now give back the word to the prorector.
Thank you for your interesting and clear presentation. What you didn't see was that one of your paranymphs fully agrees with your presentation. The opposition will be opened by Professor Paulus, Professor of Economics of Education and Healthcare, Maastricht University.
Thank you, dear Prorector. Dear candidate, let me start by congratulating you. You've written a very impressive piece of work, so I want to also congratulate your promotion team as you as well. It was a clear presentation, and it was fun reading your dissertation. But as you can expect, I also came across some questions. I have some questions related to chapters 2 and 6, where you, in both chapters and studies, look at the societal costs. Now, I want to start with a very small question, so maybe also a very brief answer. You look at societal costs. How do you define or describe these costs? What are they?
Highly esteemed opponent, thank you for your kind words and also for your question. Societal costs are costs including healthcare costs, non-healthcare costs, and costs that also include non-sectorial costs, so family burden, caregiver burden, etc.
Following that definition that you gave, you made cost calculations for osteoporosis and as well as for epilepsy. And in both cases, you looked at the societal costs. Now, largely, if I look at your chapters, the non-healthcare costs include the productivity costs. Isn't that too narrow of, let's say, a perspective on the societal costs? As you indicated, societal costs also include all non-healthcare costs. So what was the reason for narrowing things down mainly to productivity costs?
So we based our cost calculations on self-reported outcomes in both chapters. One part that we did not include is, for example, caregiver hours, how much a caregiver would need for these patients. So I agree with you. It might be a bit too narrow, but I think looking specifically on the research that was lacking, one big part was productivity losses and how much that was actually for the patient. So that's why we chose that.
You say it's a large proportion, and maybe you recognize maybe it's too narrow. So which other types of costs would you have included if you could still do this again? Just one or two examples.
Well, I think for the, like I mentioned before already, for epilepsy, the caregiver as well, and other costs for the fracture patients would be, for example, transportation costs. That we did not include now, but I can assume that if you have to come to the hospital very often, those are also costs that should be included.
Yeah, thank you. And you mentioned yourself, you looked at two different care settings. You have two patient groups, actually, those with osteoporosis, those with epilepsy. You more or less conducted, let's say, a comparable cost analysis for both patient groups. You now already indicate there are some differences. Could you clarify a little bit more? What are the differences, similarities of performing such a cost analysis for those two different patient groups?
Yes. So besides already there being a difference between in the chapters with first using the old economic evaluation guideline and then also using the new based on the time points. I think looking specifically at the costs, differences that we conducted is on one side we mainly focus on the patient-centered outcomes or the patient-reported outcomes, so the questionnaires, whereas for the surgery patients, we really also went in all the history of the hospital files, and that really makes it, in my opinion, way more complete. Even though it's not still as complete, you can always be more complete, but that's I think the biggest difference.
Yeah. Because I'm looking for, if you conduct an economic evaluation or cost analysis or cost evaluation, some things might be generic for all patient groups, and some might be very specific for some patient groups.
Okay, okay, yes.
Could you,
I understand what you mean.
compare them?
Yes. So where the fracture patients mainly visit just the outpatient clinic to get a subscription, those costs are way different than the pre-surgical evaluation costs needed for undergoing surgery. So there also I forgot the English word, but the grit assessment is needed. The patient will be hospitalized where the anti-epileptic drugs are being toned down so that we can see where the seizure occurs. So those are really way more extensive diagnostic costs that would be included there, but not for fracture costs.
Thank you. It was quite impressive to see that you looked at those two different patient groups, because normally you see one care setting, you look at two care settings. What did you learn from it? What is the added value of having two patient groups included in your study? Maybe you could mention three added values of including two patient groups instead of one?
Three added values. I think, first of all, for me personally as a researcher, I think the most important thing that I learned from this is that every care pathway is different. Every patient within that care pathway is different. So then it really also is important to analyze the different aspects. So for example, the diagnostic workup for the epilepsy patients is far more extensive, so that requires much more time in carving out what that really entails compared to fracture patients. Then again, so it's really the specifics, because fracture patients could also undergo surgery, right, to fix the fracture. But I think patient involvement is crucial to really understand where the burden lies also for the patient. So I think that's number two. Where are the hurdles for the patients and where is the impact most on the patients? So because it could be that patients, the fracture patients, really have a hard time traveling to the hospital, and that's not included. So those things could be optimized as well.
Yeah. And if you look at the challenges of including two patient groups, because we're trying to learn from an economic standpoint what we can best do or not do, were there also challenges in having 2 patient groups instead of 1 from an economic point of view?
I think I can't really come up now with a challenge.
That's fine. That's fine. As I said, it was very impressive that you already look at it. If I understand it correctly, in some of the studies you took the cost perspective and calculated the cost for 1 year. Or, if you would take it to the longer term, let's say, because you indicated it differs between patients with epilepsy and those with osteoporosis. From an economic perspective, would that be more challenging for one group over the other?
Yes, that I do agree. I think the timeline is definitely a challenge. So they're both chronic diseases. So I think if you would have a non-chronic disease, it would already be different. But looking at only chronic diseases, the fracture patients, the effect of anti-osteoporosis medication is often only seen in the long run. Yeah. And patients don't really have that much of a burden as epilepsy patients have. I think the timeline was also a bit more difficult for epilepsy patients as you can imagine, when a patient is undergone surgery, the first year we see now doing this research is really still an adjustment period. And we only saw in the second year that patients started to find their normal again. So ultimately, you would always want to have a longer timeline.
Thank you very much for your answers. I give the floor back to the prorector.
Thank you. The opposition will be continued by Professor Zijlmans, Professor in Epilepsy, University Medical Center in Utrecht. Thank you for joining via the World Wide Web.
Thank you. Well, I would also like to congratulate you with your efforts, and also extend those congratulations to the team of supervisors, because I think it's an enormous job, but of course important. I see my screen is a bit okay. I have a question, of course, as I come from the epilepsy side, I will have questions about chapter 6 and 7. And my question about, the first question is actually very general. If you, because now you took a patient group of 30 or 44 patients, all adults, how would these results extend, for instance, if you would try to translate this to, let's just take something like other places where they perform epilepsy surgery, Italy or India, or if you look at, if you would include children, how would that affect your findings, do you think? What do you think?
Highly esteemed opponent. Thank you for your congratulations and for your question. I think there's a big difference between countries because every country organizes their healthcare system differently. So I think, and also their non-healthcare system differently. You see, for example, in Italy, the care is often provided within somebody's house, whereas here in the Netherlands we have a lot of care centers or rehabilitation centers where patients can go to. So I think costs would definitely differ. Probably the diagnostic workup will be similar, but there will be some changes. So for example, some countries don't really have that well access to MRI, for example, Lithuania. So that's already something that should be adjusted for, and they probably have different guidelines on how to deal with that. That would influence the costs. Looking at children, now I'm not a clinician, so I'm not sure how the care pathway or how patients are treated differently from adults, but I'm sure that it's not directly translational. And I think it's also important to note that this was a small sample, so this was just a pilot study, and to really have more conclusive results, we should have, especially on the costs, we should have a larger group or sample.
And in very general terms, do you think the cost benefit increases in for instance, low-income countries like India, or what do you think about that?
I'm not sure I can have a final answer on this, because I think that also depends on which perspective the guidelines state for those countries. If we look at the societal impact, for example, I think it might be less cost effective because it might be more costly. On the other hand, I'm not sure whether the healthcare costs are indeed higher in those countries. So that's something I'll have to dive back into the literature for.
Okay, thank you. And another question I had was about Chapter 7 and Table 5. To be very honest, I do not fully comprehend what is happening here. And one very general question on this is, so there are 44 patients, and then most of them are seizure-free after surgery, but few are not. And in the table are a lot of factors, but I do not see. Well, there's seizure freedom maintained, but yeah, I would expect that if the patients were seizure-free after surgery, yes or no, would have been a factor in your model that would really be compared to the other outcome measures. Because now, as you said, there are effects have been found, like the BMI and the gender and the having had a ketogenic diet. And to me, that feels totally random, to be honest. So, because I feel like that, for instance, the ketogenic diet and the duration of the pre-surgical evaluation and if there was a resection previously, I would expect that those are the patients who have like a worse outcome and therefore higher cost, and that, for instance, the gender. Well, I don't know. I mean, that has nothing to do, of course, with outcome. Yeah, so I wonder how that how I should see that in this table, and if you can comment on that. Like, because I saw in the other schedule, you see there's a big difference among patients, which we can expect. So are we in this table looking at outliers or just the outcome of surgery? What are we actually looking at?
Okay. So as this was just an exploratory study, we tested all possible variables that could have an effect. The reason I agree with you that a variable such as seizure-free after surgery, yes or no, could be included. Personally, I found it more important to understand whether the patient maintains seizure freedom at the end of 2 years, because there were some patients who were seizure-free but then had a relapse or had seizures coming back. But it is definitely a variable that I could have added in, looking back on it now. Looking at other variables such as ketogenic diet, having more healthcare utilization before the drug-resistant epilepsy diagnosis, having already had a surgery prior to this, all hint at a patient being more complex, and therefore we tested them individually. The other option was also to test for multiplicity, but we chose not to do that, as that would increase the number of false positives as type 2 errors. And mainly because this is such a small sample size, then you would have more false positives, false negatives, sorry. And therefore we only looked at all the variables that we had now. But I indeed also think that in hindsight, we could have also used an additional variable where we tested seizure freedom, yes or no. Does that
what I find it does answer the question, because of course the question is, does your results suggest that we should perform more surgeries in general, or should we perform more successful surgeries?
Our research suggests that we should perform surgery earlier. So we see that the duration is from the moment the patient stepped foot into the hospital up until drug-resistant epilepsy diagnosis was on average 12 years with a standard deviation of 19. So if we then also looked at, I think there was a paper in 2021 that expressed the underutilization of surgery. Within the Netherlands, there should be 2,100 patients eligible for it, but currently there's only 2 centers who do the operations and 130 patients being operated each year. So I think this only confirms that surgery should be done earlier on and not per se more or less, or not at all.
Thank you for your answers, and I'll give the word back to the chair.
Thank you. The opposition will be continued by Professor Pavlova, Professor of Health Economics and Equity at this university.
Dear candidate, my congratulations to you and your supervisory team for this important dissertation. You have investigated an important topic also with global relevance, as we just heard, and relatively recent research focusing on quality of care and patient-centeredness, which is very important. I'm sure that your dissertation will be very useful and will inform decision makers and practitioners about complexity of care, as you also mentioned during your presentation, and about the importance of patient-centeredness. You have already made your results known through the many publications that are part of your dissertation, and which also show the quality of your research. And I will be happy to discuss some of the points in the dissertation, but my attention was especially caught by chapter 4, where you report the results of quasi-experimental design, and I was triggered by the study design. So quasi-experimental studies typically use when we want to study causality. And we use it because we, for some reason, cannot perform a randomized control trial, either because we do not have the funding, or we do not have, or it's not ethical, or any other reason. But using quasi-experimental design by itself does not ensure that we study causality. So I would like to discuss a bit this topic with you. So, was causality direct or indirect motivation for the selection of quasi-experimental design? So that's my first question.
Highly esteemed opponent, thank you for your words and for your question. The reason we chose a quasi-experimental study was because the intervention could shape the nurses in the control setting. So that's why we first recruited the control group and only started recruiting the intervention group once the second visit of the control group was complete. The nurses were also not told any information on the study when recruiting the control group, so that we wouldn't risk any influence in the control group on behavior or influence in the patient. To answer your question, I do think, therefore, indirectly, causation was a factor.
Okay, thank you. So, quasi-experimental design, as I mentioned, they have a lot of caveats, and so they are not necessarily ensuring causality. Although that was not the direct motivation, looking afterwards, do you think that you actually study causality? Can you say that the observations after in the treatment and control group, to what extent they are actually caused by the intervention? Do you think that you have accounted enough? So you have done, I have seen that the study was carefully designed, there was matching, there were different elements in the selection of the treatment and control group. Do you think that you can be sure that there was a causal effect of the intervention?
On the one hand, yes, because the groups were very similar. There was no difference in groups. There was also no difference in centers. On the other hand, we saw that the intervention was not always consistently applied to the patient because of maybe the health literacy, but sometimes the patients also felt too overwhelmed, and therefore the nurse decided, okay, this is too much, we have to focus on the patient, which is also, again, patient-centered. But I think because of that reason, we understood that was one of the limitations of conducting it in a real-world setting. But I think having it if you really look at it black and white, and it was not consistently implemented, we could not really conclude that it is fully causal.
Okay, so the fact that you measure no effect might be different if you conduct a different study. If you can conduct a randomized control trial, do you think that you would expect different results, or you would still expect no effect if you have a different study design?
I still don't think there will be a different result. I do think there will be a different result if we look at different countries, because we did see that the control group already had a really high medication adherence, and clinical relevance of the intervention was set at 20%. So that's, if the intervention already has 80% adherence, it's almost impossible to get that clinical effect. So I do think this was the right setting for this study.
Okay, and do you think that the socio-economic status of your sample could also be the reason for not measuring effects? Are you able to match based on socio-economic status?
I think that's definitely something that we could improve on, because most of our group was white. We did not have a representable socioeconomic group of the country. So I think definitely that is something that could have changed.
Okay, and imagine that you have a big research grant, and you can continue with your research that was done for this dissertation, but you need to study causality. How you will do that? What is your suggestion? For example, in this specific chapter, you also have a bit of qualitative research there. Are you going to focus on quantitative research only, or you're going to use a mixed method, or
I think I would go back to chapter 3, where we developed the patient tool, patient decision aid. I would first run that again with more inclusive population group that would represent it properly. I would make those changes first before I even start a different or new study. And then I would, sample size was okay. Sample size I would keep the same. Qualitative and quantitative I would include again, but perhaps a bigger sample of interviews, patients, with a wider view on patient inclusion.
Okay, thank you for your answers. I have no questions, and I give the word back to the prorector.
Thank you. The opposition will be continued by Professor Evers, Professor of Public Health Technology Assessment at this university.
Thank you, Prorector. Dear candidates, well, first and foremost, I want to extend my congratulations on your beautiful thesis. I have read it with great pleasure and appreciation, and as a lot of my colleagues mentioned, you addressed a lot of topics, both methodologically but also disease-wise. And I also would like to include in this congratulations your team of promoters and all the beloved ones. Of course, we're not here to give only compliments. That would be a bit bordering for an hour. It was a bit tempting to find good questions. And one of the things I did is I read your thesis and then I got back to the statements. And I would like to discuss statement number 2 with you. And first I would like to ask one of your paronyms to maybe read it out loud, if that's possible.
The first one?
The second one.
Yeah.
Second
Yeah.
one. So, simplified language with pictorial representations of fracture risk reduction is insufficient to increase anti-osteoporosis medication persistence among patients with limited health literacy eligible for anti-osteoporosis medication after a recent bone fracture.
Thank you very much. I was reading first chapter 4, where it refers to, and then I wrote your proposition, and I thought, can you really say this, that it's insufficient, because you didn't look at, a normal decision aid versus a simplified decision aid with language and pictures. And so I was wondering, where does this strong proposition come from, and how would you defend that in relation to the things which you did in chapter 4?
Okay. Highly esteemed opponent, thank you for your congratulations and for your question. The reason I included this statement is based on the moments I took to talk to the patients. Oftentimes, patients felt very overwhelmed, felt confused, didn't really understand what the information really tried to get across. So I agree, although I did not check or did not test the way of information coming across, I do think we know that this is not sufficient.
Okay. And I could also imagine that, because you look at people with limited health literacy versus people who are not health literate, I could also imagine that, because some of the decisions made are quite complex, that it already also helped maybe the people who are not health literate, that it was helpful in a way, maybe for the total population.
So you mean that perhaps it wasn't helpful for this limited health literacy group compared to the population?
Maybe it was for the general population, and let's say it like that, which wasn't health literate, because decision aids are sometimes quite complex and we ask quite complex questions. Maybe it would be helpful for any patients in the group to have simplified language and representation by pictures.
Yeah, that could be. I do think there should be specific focus on the limited health literacy. As we also saw that the medication adherence numerically also decreased afterwards. So I think that was a clear red flag, and I think therefore specifically for that group it should be different. And we did not see that in the adequate health literacy, so therefore I'm sure it can help, but I think that would not be where my focus would lie for future research.
Okay. I would like to continue a bit on chapter 4 and a bit related to the question of Professor Pavlova, because one of the things in the quasi-experimental design is that there was a different period in time where you looked at the different groups, and you already mentioned as a limitation that the COVID pandemic and of course the AOM treatment guidelines revisions might have limited your results, but you're mentioning it just in your discussion, but could you maybe talk a bit about how it would have influenced the results? Would it be more positive, more negative, and in what way, and do they both work in a similar way?
So first, to give some background information, the treatment guidelines were changed, where certain types of medications were now actually being prescribed when previously they were not being prescribed, and this was a one of them was a medication that was an injection done yearly, which you only have to get once a year, so that's the adherence is different to measure that. The pandemic also influenced
And how did it influence your results? Would it be then?
It didn't influence our results.
Okay.
Well, based on the analysis that we did, it didn't influence it. We did normal inclusion of all patients in our main analysis, and then we did sensitivity analysis where we took out those patients who received those types of medications, and we did not see a difference. So I think there, based on the patients that we include here, there's no difference. The COVID pandemic was right in between the control group and the intervention group, and I think mentally that might have affected patients a bit. Patients could feel more overwhelmed, more drained, XYZ. And I think that could have now negatively influenced our results as thinking about it logically, how a person could feel after a COVID pandemic, staying indoors, already being old, so not moving that much. Then having to go to the hospital, perhaps more fractures occur because they're more stiff. Then you have the whole issue with people staying indoors and not wanting to leave the house anymore. So I do think that it influenced our results now more negatively.
Okay. I don't think I have time for more questions looking at the time, so thank you very much for your answer.
Okay, thank you. The opposition will be continued by Dr. Wijnen, head of the Center for Economic Evaluation at the Trimbos Institute. Thank you for coming to Maastricht.
Yes, thank you. Dear candidate, I would like to congratulate you with this well-written thesis. It's an insightful body of work, and I would also like to congratulate your supervisors. Your thesis is an interesting mix of two totally different disease areas, osteoporosis and epilepsy. And it's admirable that you have made yourself acquainted with those, with the ins and outs of both conditions. And for those people wondering how complex it really is, I noticed a really nice figure 2 in chapter 7, which presents the most straightforward patients that she encountered. And I can imagine that it was a real puzzle sometimes. So good work. But of course, I'm also sitting here to not just compliment you on your work, but I would also like to discuss with you some things. I was wondering while I was reading your dissertation. Specifically, I would like to ask you about chapter 6 and 7, in which you present research use before and after epileptic surgery. And you already touched upon this while discussing with Professor Zijlstra, but I was wondering whether you could explain briefly to us the type 1 and the type 2 errors, and maybe also related to the p-value.
Esteemed opponent, thank you for your kind words. Thank you for coming all the way here. And thank you for your question. I would like to ask for some clarification. What do you mean exactly with the type errors and the p-value? Where specifically?
Yeah, so I'm aiming at the type 1 error and the type 2 errors you can make when you're doing scientific testing with the p-value.
Good question. Now, I will give an answer, but I'm not a statistician. So
that's fine, that's fine, yeah.
Type 1 and type 2 errors have to do with false positives and false negatives with regards to a p-value. P-value is whether or not a correlation is significant or association is significant or not. Now, by using multiple variables within one test, you could have more false negatives, as you could test the presence of all of the variables at once and therefore leave out or perhaps miss chances with just one variable of those. On the other hand, false positives could be where you don't include that many variables and therefore have a false positive in relation to the p-value. So does that answer your question?
Well, yeah, it does. So if you have I think in your papers you're using an alpha of 5%, so the significance value of 5%. So what does that mean in your work?
That there's 95% chance that there's no type 1 or type 2 errors?
Yeah, I would agree with that.
Okay.
So within our department, we often have the question whether we should correct for multiple testing, yes or no.
Yeah.
And you briefly told to Professor Zijlstra that you didn't correct for multiple testing because you didn't want to inflate the type 2 error. So, so rejecting of saying that there is no difference, well, there is actually a difference, right? But I'm a bit wondering whether that's maybe too simplistic. So have you considered doing other things?
To account for
the number of tests that you have performed?
No, we did not. Considering this is a pilot study, and it was such a small sample size, I consulted with the statistician, and he said that that was not necessary. So I relied on his expertise.
Okay, so if I look at chapters 6 and 7 together, then in table 3, on table 3 in chapter 6, sorry, there are 29 regression functions, and I think in chapter 7 there are 55, and if you include the 2 supplementary tables, you have more than 200 p-values.
Yes.
So I'm wondering what the impact is of doing that much tests on your results.
The impact is merely to show, yes, I understand what your point is. I personally don't think that's necessarily an issue that there's that many tests, considering the small sample size as well. I think the impact of doing all those tests is merely to show clinicians, for example, what they can use within the consultation room to prepare the patient better. So.
Okay, but you mentioned that you don't think the small sample size is an issue, but I think you have a very limited number of patients, and if you perform then 55 regression equations on 44 patients, does that not pose a problem to the validity of the results or the generalizability?
To the generalizability, for sure. Yes, I agree. I think the research should definitely be included in a bigger sample size, and perhaps also have a better look on the multiplicity of it.
Okay. I heard Professor Zijlstra ask you that some of the results you found in that table 5 on chapter 7 felt a bit random. I would maybe go one step further and say they are maybe random. Maybe the effects you find are random and just due to chance because you have so many tests and given the type 1 and type 2 errors. What would you say, what's your take on that stance?
I think considering the 5% alpha, I don't think they're per se at random. I do think there's definitely some additional questions that arise. So for example, the BMI is higher and therefore also higher costs, therefore lower costs. That's questionable. So I think there might be some random points, but there might also be an indication that we should take with us to future research.
Okay, so in hindsight, is small question still possible? So in hindsight, you say you didn't want to inflate the type 2 error because you didn't correct for multiple testing, but could you also limit the type 1 error due just performing less tests? That's my question.
That could be.
Okay. Thank you for your answers. I'll give the word back to the
Thank you. This was very tough.
Yeah.
The opposition will be continued by Dr. Speetgens, internist, ouderengeneeskunde at the Maastricht University Medical Center.
Thank you, Ms. Prohector. I had to change seats because there was no microphone, but I will not take this personal, so that's okay. Dear candidate, I read your dissertation with interest, and I wish to congratulate you and also your supervisory team, family and friends with the results. And you've done a great amount of work in a remarkably short time, so that's very interesting. I'm always fascinated by the cover of a PhD thesis, and as they often carry a symbolic meaning, and I saw the cover of your thesis, and then I saw this large tree fully in bloom with its roots in, I believe it says data, ones and zeros. But then I was a bit shocked that after 270 pages of hardcore science, you see at the back just this little sprout left with no roots in the data anymore, but because I just hope that's not all that's left, right?
No, it's a seed for new research.
Okay, thank you. Then now I'm reassured about that. As an internist specialized in geriatric medicine, it would not be surprised to you that I would like to focus on the fracture patients. And my first question is about chapter 3 and about your decision aid. And yeah, of course, I always like to see a decision aid, but as an internist specialized in geriatric medicine, I see the most old and most frail patients. And does your decision aid has value for this population? That's my first question.
Esteemed opponent, thank you for your kind words and for your question. I think we adapted the patient decision aid specifically for older patients. The patients in our group are on average 70 years old. And we chose for a paper version so that patients could take it home, read it in their own time again on their own pace, etc. So I do think it adds value for specifically older people.
Okay. For older people, yes. You say age 70. Do you also have an idea on the most vulnerable or most frail patients? As I internist geriatric medicine, I see patients with hip fracture lying in the hospital. So do you think these patients also have value of this decision aid?
I do think so. But again, I think to generalize it might be difficult. There's some patients who are age 90 and are still very sharp, whereas there's some patients who struggle more with that. I think the type of fracture also plays a big role, where hip fractures are way more invasive, really affect the patient much more than smaller fractures like a finger. So I think all in all, I think it can still provide that extra information that some patients might be looking for.
If we zoom into this hip fracture patients, because it's a line of research that I perform some studies in, do you think it still has value then? Or is this a population that does not need a decision aid?
I think it depends on the type of hip fracture. There are different types of hip fractures. While some fractures might require surgery, other fractures, I forgot which types, but there's some hip fractures that would require the conventional type of treatment. And I think for those type of patients, it's specifically valuable. Okay.
You already mentioned the new treatment guidelines. Do you know the new treatment guidelines for patients with hip fracture?
Not by heart.
So essentially every patient with a hip fracture that's age 70 years or older, whether or not this patient is being operated on, you can consider, it's what all guidelines you can always consider. So if you make another decision, it doesn't matter, but you can consider, and it's highly recommended to treat these patients with anti-osteoporotic medication. And these patients, you can give them 1 yearly intravenous zoledronic acid. And there are now sounds to do this in hospital. If the patients have fractured their hip and they are still in the hospital, you can give this IV medication, and then you are done for 1 year. And then after that year, you can see where the patient is, or what you have to do, or you need to follow up the osteoporosis. Isn't this a method that should be pursued for all patients? And just leave out the decision aids, just stop with decision aids. You have shown it's very difficult to do research.
I think that's a question that I could not answer with this research, because with this research we got additional questions. For example, is it actually on the long term beneficial to offer a patient decision aid where patients can also choose to not be treated? And that might not be the best clinical decision for the patient, yet they do get that choice. So I think the patient decision aid should still be further elaborated on, and we should first answer those questions in the long run before we start implementing it on a wide scale.
Okay, I think it's a nice answer, and I believe that in your answer is hidden that you find it important, or it's not even hidden, but you find it important that the patient may decide to be treated or not be treated. So shared decision making is an important process.
Yes.
Okay. Then I would like to go with you to chapter 4.
Okay.
And we have already been there a bit in discussion with Professor Pavlova and Professor Evers, but I would like to ask another question. In chapter 4, and we already had it about the design and the quasi-experimental, or it should be randomized, but you showed that this multi-component adherence intervention does not significantly improve adherence to the osteoporotic medication. Shouldn't we then just stop this intervention? And if not, why not?
No, I don't think so. I think the group that we had was in 2 centers that the fracture liaison services was already very good quality, internationally speaking, meaning that the control compared to the intervention is obviously already, the numbers are already higher. I'm not sure what the average medication adherence is, but it's definitely lower than 70%. And initially, we based our research on the medication adherence being 51% in one of our clinics. If that would have been 51%, then it would have made sense that there would be a difference.
Thank you.
Thank you.
Lieke Maas, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. And I request you and your company to await the results of our deliberations and our return in this room.
Thank you very much.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Southside, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Your mind, years can't fly by now. Don't waste all your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. Southside, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Lieke Maas, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the committee has decided to grant you the degree of doctor. Dr. Hillixman is authorized to confer upon you this academic distinction in accordance with Dutch university custom. And I invite your supervisor to now take the floor.
Thank you. Do you promise to work in accordance with the principle of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Lieke Maas, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other member of the committee, and affixed with the official seal of the university. Dear Dr. Maas, dear Lieke, dear colleagues, friends and family, member of Lieke, it is both a privilege and a pleasure to be the first to congratulate you, Lieke, on your extraordinary accomplishment. Over the past 2 to 3 years, I have had the opportunity to witness your growth, dedication, and deep passion for your work. My journey with you began during your master thesis, which you completed in collaboration with MSD in Brussels. From the start, you stood out not only for your impressive knowledge and skills, but also for the enthusiasm you brought to your work. Your keen attention to detail and natural efficiency were evident right away. Shortly after, I had a project with Annelies that needed some support, and it was the perfect fit for you as you were completing your second master degree. Yes, you have not only 1 PhD, but also 2 master degrees. Due to budget constraints, however, the idea of a traditional PhD 4-year track wasn't possible, despite interest on both sides. But you expressed your desire to pursue a PhD regardless in a shorter time frame. And we both wonder whether this could be done in about 2 years of time. And I still remember you coming to me with the question, could such an ambitious project really be completed within such a short period? And with your ability in mind, I say yes. So I knew it would be very, very challenging, a path that few researchers could realistically take on. But today, here we are. You have achieved it, Lieke. It was thus possible. Many congratulations. You have completed your PhD in an incredible short period. But let me emphasize that the quality of your dissertation is remarkable, and you have acquired all the skills needed to become a doctor. And in addition to completing your PhD in record time, you have already published 5 papers with 1 more in revision, and your master thesis was also published and even not included in your dissertation. This level of productivity and quality is truly rare, and you can be very proud of it. During your PhD, you maintained a level of dedication and productivity that I believe few could match. You approach each part of your work with purpose, ending a demanding schedule while consistently delivering high-quality research. Your strong organizational skills and forward-thinking approach allow you not only to meet the milestones, but also to achieve them with precision and excellence. Your collaborative spirit also makes working with you a great pleasure. You bring such enthusiasm and positivity to every task, viewing challenges as opportunities for growth and new discoveries. You even manage the complex task of working with 3 supervisors, each with a totally different background, a testament to your flexibility and ability to bring people together for a common goal. And I also would like to take this opportunity to thank all of the persons that were involved in your research, because designing a patient decision aid, making a clinical trial also requires a lot of people, and also a big thanks for some doctors and nurses that are also in the room for their contribution to your studies. And I'm also speaking on behalf of the entire supervision team when I say that we are grateful to have worked with someone like you. I also remember how you often ask at the end of our regular meeting if there was something you can do to help me, and always thinking about how you can be helpful even if you were very busy yourself. And I think I only asked you once at the end, a very small task. But this achievement, this PhD, is something you can really be incredibly proud of. Completing a PhD in such a short time has set a high standard, and your success reflects not only your intellectual abilities, but also your perseverance, your commitment, and a strong belief in the power of hard work. It has been my privilege to support you on this journey alongside Annelies and Kim, and I have no doubt that you will go on to make even more remarkable contribution in your field. And I'm very happy to continue working with you and look forward to seeing all that you will accomplish in the coming years. I'm certain this is only the beginning of what will be a great career. Just please join me in congratulating Lieke on this exceptional achievement, and her success inspire us all, and it has been my honor to be part of the journey.
Thank you so much.
Congratulations.
Thank you.
Dear Dr. Maas, also on behalf of Maastricht University, I'd like to congratulate you with your achievements, and also I want to congratulate your supervising team, and it was a great job. Before closing the ceremony, I want to give the floor to Professor Zijlmans for a short word.
Yes, thank you. Well, congratulations with this great work, and I'm always happy if somebody who's not a doctor is willing to look into the fields of epilepsy and healthcare, which is so difficult. So again, congratulations.
Thank you.
Thank you. After closing the ceremony, I invite all the people to go to the reception room. We stay here for a little moment to make some pictures with Professor Zijlmans on the background and pictures on the stairs, and then we join you also at the reception. And daarbij I close this ceremony.